Good morning, everybody. First of all, I want to congratulate my dear brother and friend, Professor Ahmed Abdelhadi, for this regular event. And wish him all the success, and I'm enjoying this meeting, and I'm waiting this meeting every other month, every 3 months, and I wish him all the success. Now we are going to start the first session with breast cancer, and it's my pleasure to have with me Professor 𝐒𝐚𝐬𝐬𝐜, the well-known pathology all over our country, and she's going to introduce the first speaker, inshallah.
Thank you very much. الحقيقة باثولوجي أنا molecular biology. عشان مش عاوزين نتخانق مع شادي. شادي هو الإيميننت باثولوجيست اللي عندنا الحقيقة، واللي إحنا we rely upon him على الحقيقة في الحصول على good quality biopsy tissue. طبعا this is a very rich session الحقيقة dealing with the updates on HER2 testing and evaluation in the new era of drug conjugates. فالحقيقة يعني في eminent speakers. هنبتدي الأول بالباثولوجي. دكتور شادي إيليا أستاذ الباثولوجي الهيستوباثولوجي في كلية طب جامعة القاهرة، صديقنا في القصر العيني. والحقيقة الباثولوجي is one of the important milestones for the good diagnosis and evaluation of the stage and the type of the malignancy. فبالنسبة للهير2 بالنسبة للبريست كانسر الهير2 تيستينج مهم جدا. احنا في الباثول احنا ايفالويت الهير2 اكسبريشن، وده اللي بيشوفه الدكتور شادي إيليا in the shape of proteins produced by HER2 positive breast cancer cells. الحقيقة في ميثود تانية اللي هي الهير2 اكسبريشن RNA evaluation في التيومر. Both methods are concordant، والحقيقة احنا يعني حاليا we rely on the immunohistochemistry of the protein product of the HER2 breast cancer positive cells. اتفضل يا دكتور شادي.
Thank you دكتور وفاء على ال presentation. I want to thank دكتور أحمد عبدالهادي على الدعوة الكريمة اللي دايما بتشرف بوجودي في وسطكم فيها. Today we will talk about updates on HER2 testing in the new era of antibody drug conjugates. The expression of HER2 as immunohistochemistry is artfully divided into 4 scores: 0, 1+, 2+, and 3+, which is nowadays يعني same بس 3 modified نسبيا as negative and HER2 low بين قوسين ultra low and HER2 positive carcinomas. I want to make a note at the start of our lecture. We have to know that the assay of HER2 اللي هو HER2 by immunohistochemistry was not originally designed to detect the HER2 low expression. It was actually designed to detect the high expression of HER2. The issue is, normally each cell in our body is having about 20,000 HER2 receptor on its surface. Normally, مش بنتكلم على tumor. Okay? لكن الtumors can reach up to 2 million receptors on its surface. So when it was designed for the antibody was designed, it was designed to detect the overexpression, not the normal. So it was calibrated that the normal cells that have 20,000 receptor by immunohistochemistry to be 0. So actually 0 does not mean that we do not have HER2 receptors. Okay, it means that we have about 20,000 receptors, and this issue will be important in our lecture further. HER2 low expression does not define a new molecular subtype of breast cancer. Rather, it is a biomarker common to all molecular subtypes. There is a retrospective a study performed on the prevalence of HER2 low in HER2 negative unresectable metastatic breast cancer. And it was found that HER2 low was more prevalent in hormone positive cases, 71% to 52% in the in the hormone negative cases. But fortunately, the comparison between the primary and metastatic, it was almost the same, and the results between the Ventana 4B5, which is the most reliable one antibody used, to the non-Ventana ones, the difference was not very big. The challenges for a pathologist of reading HER2 are the same for the ones for the PD-L1. Why? Because we have different antibodies in the market with different detection systems, which leads to sometimes different results. We have different platforms, يعني machines مختلفة بنستخدمها. We used to have different scoring systems, but now no. And the heterogeneity of the HER2 among tumor cells. Fortunately, we have now the validated assay, which is the 4B5 provided by Ventana, which is a companion diagnostic test in USA when it is performed on the Benchmark Ultra platform. So it's reliable to detect the HER2 low cases. There are barriers to the identification of HER2 low breast cancer. First, distinguishing IHC score from score 1+ was not pursued in the daily practice of a pathologist, except recently. So pathologists do not have a lot of experience in differentiating these. The concordance among different antibodies and assays for scores 0 and 1+ has not been fully evaluated. Sometimes you can have a 0 with a 4B5 and a 1+ by another assay. Predictive value of alternative assays and scoring system has not been investigated. In the retrospective study I talked about 2 slides ago, there were difference between the historical evaluation and the rereading of the HER2. So there was a difference between the historical HER2 IHC 0 and the rescored IHC 0, and the concordance or the positive agreement was about 70% only. About the HER2 low, the positive agreement between the old reading and the new reading was about 87%. We still have some questions in this issue. Is there a correlation between the percentage of cells with low expression of HER2 and the efficacy of TDXD treatment? Putting into mind the tumor heterogeneity, which means that sometimes I have a core biopsy with 1% low expression, which is ultra low, but maybe you will take another biopsy from another metastasis and you will get a 15% expression. So, which is the real one? So there is no real one. The tumor is heterogeneous. So it is very difficult to correlate between the percentage of cells, because you will not be sure of the real percentage of cells expressing HER2 in a low expression way in the whole body tumor. Is there a correlation between the type of intratumoral heterogeneity, which means sometimes the heterogeneity is in cluster? You have a tumor, for example, I have a complete block with an aggregate of positive cells, or I have a complete block with a cell here and here and here. So it's kind of heterogeneous. This is 10% and this is 10%. So will this affect the results of TDXD? We don't know. Do outright negative HER2 null tumors respond to therapy? And this was partially answered in the DAISY trial, in which we have 3 cohorts. cohort 1 with HER2 overexpression, cohort 2 with low expression, and cohort 3 with no expression at all. And the best overall response was about 70% in the overexpression, 37% in the low expression, and 30% in the no expression. So what to do following the approval of TDXD for HER2-low breast cancer? It's important to alert the scientific committee on the introduction of HER2-low concept, and this is what we are doing now. We educate and train the pathologist for an accurate and reproducible report of HER2-low and ultra-low status. And do not forget that intratumoral heterogeneity of HER2 status must also have an important role in informing the choice of anti-HER2 therapy. So, HER2 testing by the eye of a pathologist. We have two ways of assessment for a pathologist, apart from the RNA Dr. Wafa mentioned. We have immunohistochemistry, which detects the expression of receptors on the surface of the tumor cells, and the ISH, which is the in situ hybridization, which detects the number of genes, HER2 genes in the cells. As we all know, in the 2018 CAP guidelines, there was 0, 1 plus, 2 plus, and 3. The positive was the 3 plus and the 2 plus ish positive, and this didn't change, okay? And the negative was the 0 and the 1 plus and the 2 plus ish negative. This is changed in the 2023 with low expression HER2, which is the 1 plus and the 2 plus ish negative. This is what we see under the microscope. This is the strong continuous cell membrane staining, which we call score 3 plus. This is a moderate to weak expression but circumferential cell membrane staining. This is what we call 2 plus, and this is a higher power for the 2 plus. And this is the incomplete cell membrane staining, which is faint, and by definition it is barely perceptible. So sometimes you cannot see this expression except when you go to high power. يعني high power أنا عندي في الميكروسكوب في different powers. بشوف scanning power، بشوف التيشو كله، وبعدين higher power بقرب لغاية لما أوصل لأن أنا بشوف a small group of cells in my field. فلما أكبر قوي أقدر أشوف الإكسبريشن ده. This is a high power with the incomplete, barely perceptible expression. Unusual patterns of staining. We have the intratumoral heterogeneity, as mentioned before. Some of the cells are negative and others are positive. Some of the cells are expressing the protein in a strong way, and others are expressing it in a low expression way. Sometimes we have a cytoplasmic expression, which makes some of the confusions between some pathologists, because I can interpret this as cytoplasmic, and other pathologists can interpret this as weak cell membrane staining together with the cytoplasmic. This will make a discrepancy between our results. So this is a difficulty. The difficulties in reporting the HER2-low category related to the reading pathologist and related to the sample quality. The problem with the reading pathologist is that pathologists, except for the last year, did not care to make the distinction between the HER2 score 0 and score 1 plus, because both used to be reported as negative in the last years. Or previous years. Cases with weak, barely perceptible staining should be carefully examined by high-powered, as I previously mentioned, to differentiate between the incomplete cell membrane staining and the cytoplasmic or the no staining at all. For cases with weak, incomplete cell membrane staining, the pathologist should distinguish between those showing 10% staining or more, which is the score 1 plus, and those who are less than 10%, which is recently called ultra-low. This is an example of a difficult case. This is it score 0 or 1 plus? Is it true cell membrane staining or no? The staining of cells, does they reach 10% of tumor cells or no? على قد الصورة شكلها سهل ان انا اميز، لكن لما when you have a big section and you go to high power and you try to scan the whole areas of the section, it's not easy at all. You can miss a small field with 2 or 3 cells that can be positive and you miss them. So you can call it, it's a null zero, but it is an ultra low zero. Okay. In this case, score 0 or 1 plus, is there nightmare, not ours. لأنه you are dealing with patients and your treatment will not respond except if the tests are really right done. يعني sample preparation, fixation, and further processing is very important. So we have together to teach our dear surgeons and our dear radiologists to deal with the specimens in the right way for proper fixation عشان نوصل ل high quality DNA عشان نقدر نوصل، وده اللي الدكتورة وفاء definitely بتعاني منه دايما، انه يوصل لها tissue with very poor DNA فيطلع poor results. I want to mention that مش المشكلة دايما مش بس عند السيرجنز او الراديولوجيست، لا في مشكلة في بعض معامل باثولوجيست definitely، انه اوقات ان احنا مثلا نعمل اوفر هيتنج اوف ذا تيشو، اوقات ده بيحصل سواء في البروسيسنج سواء في الامبيدنج. يعني احنا we are dealing with this with our colleagues in pathology عشان نوصل للoptimization of fixation and processing. Yeah. We have another problem is the metastatic bone lesions. الحقيقة إنه sometimes I call مثلا دكتور أحمد مثلا ويقول لي I don't have any lesion now except the bone lesion. So we have to deal with it and we have to perform the HER2 on the bone lesion. The problem with the bone lesions is that there is a step called decalcification, and decalcification can harm the DNA in most cases. But recently there is the EDTA, which is another way of decalcification, but it is a way of slow decalcification. And this is a problem in our culture. We need the result the next day. I don't want to wait for a week. And the slow decalcification takes about 48 to 36 hours. So it takes time. Sometimes the pathologist, to relieve this headache of pressure, they go with the rapid decalcification, and unfortunately this destroys the protein and the DNA on the surface of the cells. How the pre-analytics affect the HER2 staining quality? This is the quality is related to 2 factors, the cold ischemia time and the fixative itself. Cold ischemia time, this is the time between the acquisition of the biopsy and putting it into the fixative. Sometimes the surgeon takes the specimen out and give it to the worker or to the nurse, and the nurse keeps it on the table for about 3 hours till the end of the operation, and then she puts it in the fixative. And this means that cold ischemia time here is about 4 hours. And the degradation of proteins and DNA starts after 1 hour after the acquisition of the specimen. So this means that the results of this specimen won't be accurate. Okay? So we have to put the specimens into the fixative right away. So you can see here the difference between the first biopsy, which was put after 30 minutes into the formalin. You can see the expression of HER2 here. The expression is very strong and diffuse. This is the same biopsy, okay, but another part of it, same tumor, but the cold ischemia time is 2 hours. You can see the difference of expression, so you will get a different result. The same for the 𝐻. The signals will be clear when the cold ischemia time is less than 1 hour, while the signals will fade. Sometimes you get reports that the signals are very weak and we cannot count them. This is the problem, is the lung ischemia time. So with lung ischemia time, the cases that are actually score 3, you can get a result of score 2 because the expression is lesser. And the cases with score 2 plus, you will get a result of score 1 plus. And this is critical. Why? Because the 1 plus, you will not proceed for the 𝐻. But the 2 plus, you will proceed for the 𝐻, and you will find out that this is an amplified tumor. But for the 1 plus, you will not. But actually, it was amplified. So this is very critical. And the 1 plus, you will get a score of 0. So you will not give the TDXD also. These are the CAP updates and the reporting of breast hormonal receptors and HER2. It was given in March 2025. And they are refined reporting categories into 0 without cell membrane staining, which we call the HER2 null, 0 with faint, barely perceptible staining in less than 10%, which we call ultra low, and I will tell you what I mentioned, which we call. And the 1 plus, which we call HER2 low. Actually, HER2 low, ultra low, these terms were not adopted by the CAP. And this is why they mentioned we didn't adopt these terms, and I will read them for you. The guideline panel did not find evidence that HER2 low was a prognostic or predictively distinct result category. The panel had concern that changing the interpretation of HER2 IHC 1 plus and 2 plus 𝐻 negative to HER2 low would incorrectly imply that the breast cancer samples with HER2 IHC 0 results, which are negative, do not contain low levels of HER2 protein expression. وده اللي أنا قلته في أول محاضرة، إنه كده هنفهم خطأ إنه الزيرو. Okay, I know that the time is over. I can have just 2 minutes. Okay. فنفهم خطأ إنه الزيرو ده معناه إن there is no HER2 expression خالص, which is not true. فعشان كده هم بيقولوا we did not adopt الترم HER2 low عشان كده، رغم إنه هو actually للتعامل ما بيننا وما بينكم as pathologists and oncologists is very useful. HER2 IHC assays were designed أصلا to distinguish high levels of protein overexpression due to gene amplification from those that lack overexpression and do not and not to accurately detect and distinguish protein levels in the lower range of expression. So هو معمول عشان الهاي range of expression مش اللو range of expression. اللي احنا بنعمله دلوقتي احنا بنحاول نستخدم حاجة كانت معمولة لحاجة تانية. فاهمين الفكرة؟ عشان كده الاكيورسي بتاعتها kind of questionable. Available data support that HER2 IHC 0 versus 1 plus results are not consistent across samples, primary versus metastasis, and that more sensitive assays do in fact identify the frequent presence of low levels of HER2 protein in IHC 0 samples. More data from clinical trials that include IHC 0 results are needed to determine if these cancers also contain enough HER2 protein for trastuzumab deruxtecan response, or if there is a definable HER2 low category using another assay that can predict response. The limited clinical trial data currently available from the single-arm DAISY trial suggests that metastatic patients with IHC 0 result may respond similar to those with IHC 1 results. As a summary, previously HER2 can just positive and negative. Currently بقى HER2 positive اللي هو 3 plus و 2 plus 𝐻 positive زي ما هو. HER2 low newly introduced, which is HER2 plus and 1 plus 𝐻 negative. HER2 ultra low, which is HER2 0 with membranous staining, and HER2 null, which is 0 without membranous staining. To accurately apply the CAP new guidelines, we have to have well-trained pathologists and pre-analytical tissue optimization, which is called the ischemia time and the fixation. Thank you very much.
Thank you, Professor Shady. Actually, I want to thank you for two issues. For your presence with us today, while you have your feast, I think today and the coming days. And second, for this nice lecture. And it's not, it's not the first time, and I know you and Professor Elia, that's common for both of you. I wish you a happy feast, and because of the tight time, and we have some people have questions. Professor Ahmed Abdel. Yes, عايز تمشي.
ايه الرول اوف الاي اي في الديستنجوش بين الهير2 0 والهير2 نل؟ اللي انت يعني لسه عارض انت سلايد دلوقتي اتس ديفيكولت كيس. فهل الاي اي هيبقى له دور ان احنا ما نعتمدش على الهيومن ايرورز؟
Definitely AI has, يعني I believe in it will have an important role in the future. It started now, وفي دلوقتي assays that are approved to evaluate the HER2 زي ما دكتور أحمد قال. The problems is you have to have, in my opinion, several AI programs to see if there is real concordance between these AI tools. And no, actually, some data that are emerging that when you use different platforms for AI, you can even get different results for HER2. And this was mentioned by Professor Vialli, which is a very well-known, وهو كتير من الريزلتس اللي أنا قدمتها دي ده شغله هو. فهو he has experience in this, and I asked him وقال إنه we tried to do this, and between the different AI platforms we had some discordance تقريبا similar to the human factor. Still we are ameliorating the AI platforms. Maybe someday, I believe very soon, there will be good concordance between these.
معلش كلمة أخيرة. Thank you very much دكتور